This week we're learning about pre-transfusion testing and serological systems. There's a lot of reading material, so I created this video to help you cut down on reading. If you'd like clarification, refer to the Word document posted in Blackboard. Previous technical manuals had flash drives, but the latest version offers a Word document, so you'll find that again in Blackboard. Each of these methods, I don't know if you've read these before, has a principles, a materials, a procedure, and then a notes area. The principle and the notes area should be your primary concern as you study. The materials and procedure area can actually vary between manufacturer and hospital, so memorizing the drop number and the incubation time is not a great use of your study time. It really can vary, so please focus on the principle and the notes area because understanding the reason why we're doing the test and the limitations involved is very important to your learning. Method 1-3 refers to treating incompletely clotted specimens. The principle states fibrin generation may continue in serum separated from incompletely clotted blood, especially during incubation at 37 degrees Celsius. The fibrin generation produces strands of proteins that entrap red cells and that make it difficult to evaluate agglutination. Blood from patients who have recently received heparin may not clot at all, and blood from patients with excessive fibrinolytic activity may reliquefy or may contain protein fragments that interfere with examination for agglutination. So all of these procedures will remove substances so we can observe agglutination more easily. This method reviews 3 unique procedures which aim to remove interfering substances impacting the integrity of the sample due to insufficient clotting, like I just said. The first procedure discusses how to accelerate clotting. Referring to the principle above, decelerated clotting is due to fibrin generation, which entraps red cells and makes it difficult to evaluate agglutination. The procedure goes as follows. To accelerate clotting, we'll add a certain amount of dry thrombin. We can also have the option to add a thrombin solution. We'll add this to whole blood or serum and allow the sample to clot after about 10 to 15 minutes. We'll use a standard centrifugation to separate the clot and the serum, and then we'll gently agitate the serum with small glass beads and spin at a low-speed centrifugation to pellet the glass beads. We'll then transfer the serum to another tube, and the hope is that the thrombin has removed the fibrin, and we can now go ahead and test this sample without any interference. As stated in the principle section, we'll go on to the next procedure. A patient who has recently received heparin may not be able to clot at all. A procedure which can eliminate heparin from the patient's sample to allow the sample to clot is a neutralization procedure. We will discuss neutralization methods later on, but to summarize, adding a substance to remove an interfering substance in a sample of serum or whole blood constitutes a neutralization treatment. In this example, we use protamine sulfate, substance 1, to remove heparin, interfering substance number 2, to allow the specimen to then clot. Therefore, patients who have heparin therapy have samples which are not properly clotting, may require protein sulfate additive to induce clotting in vitro. Take note that this question has shown up on the SBB exam, so ensure you understand this procedure. The procedure also notes that rouleau formation can occur if excess protamine sulfate is added, so be liberal with the amount that you are adding. As we know, rouleau formation can appear to be agglutination even though it's not. The procedure is rather simple. We add 1 drop of protamine sulfate to 4 milliliters of whole blood, and we wait 30 minutes to evaluate the effect on clotting. If the clotting does not occur, we'll add protamine sparingly. The protamine sulfate may work more rapidly when briefly incubated at 37 degrees Celsius. On the left side of the screen, I've added how heparin impacts the coagulation cascade. Recall that we have the intrinsic pathway, the extrinsic pathway, and then we have the common pathway. Heparin acts on the common pathway when it prevents the conversion of fibrinogen to fibrin. Thus, the patient is unable to form a stable clot. Onto our third mechanism. We're going to discuss how to promote clotting in patient samples who may have elevated fibrinolytic activity. Excessive fibrinolytic activity, per the principle above, can lead to reliquefaction of the sample. The procedure is very simple. To inhibit or prevent any fibrinolytic activity, we're going to add 0.1 mLs of a solution called EACA, which stands for epsilon aminocaproic acid. This substance inhibits fibrinolytic activity, like I just said, and recall that fibrinolysis is the breakdown of a fibrin clot. In this scenario, factors in the patient's sample are accelerating the breakdown of the clot. This substance is added, the EACA, and the clot formation can continue as normal, so we can then separate the clot from the serum and perform our testing. Note that the use of anticoagulated collection tubes, as noted in our limitations sections at the bottom, may help to avoid the problem of clotted specimens. Therefore, we do not often encounter these procedures in the blood bank because many of our tubes arrive in EDTA-coated tubes. Second, there is a possibility of false positive reactions, especially with thrombin and protamine sulfate procedures. Each lab should always validate the performance of treated samples to determine that the samples behave as expected in the testing system. So if you use the protamine sulfate method to inhibit heparin, you'd have to validate this in your laboratory to ensure that the procedure reacts as it should using your method. Method 1-9, reading and grading tube agglutination. The principle states the purpose of grading reactions is to allow comparison of reaction strengths. This purpose is beneficial in detecting multiple antibody specificities or antibodies exhibiting dosage. The materials are a centrifuge and agglutination viewer. Just a note on the word agglutination. You'll observe in some laboratories that they use the word precipitation to refer to clumping. However, in the blood bank, agglutination is a process that occurs if an antigen is mixed with its corresponding antibody, and we observe clumping macroscopically. So when I teach different individuals from different laboratories and they come into the reference lab, I always make sure to differentiate between precipitation and agglutination. The procedure is straightforward. The first action, we gently shake or tilt the tube to resuspend the red cell button in the tube. The tilt technique uses the solution meniscus to gently dislodge the red cell button from the wall of the tube. The next action, we observe the way the cells are dispersed from the red cell button. The third action, we record the reactivity concurrently by comparing the agglutinins to the descriptions in the table listed below. The reactivity should be assessed when the red cells have been completely resuspended from the button. Step 1 procedure is where blood banking can become subjective. Agitation involves gently shaking or tilting the tube to resuspend the red cell button, which forms after centrifugation. Technologists can shake tubes at different vigorous strengths. It's important during training to ensure technologists with less experience understand the value of gentle agitation and the method that is standardized in the blood bank. We then, in action 2, observe the way the cells are dispersed and concurrently record the results. Although this procedure method is rather simple, the value of reaction strength in patient testing can become complex and very valuable to know. Because antibodies do not always react as they should, and our testing is limited by the reagent source, IRL technologists rely heavily on the strength of reactivity to narrow an investigation. Some examples in which strength of reactivity is important include variant antigen expression during phenotyping, HTLA investigations, and even failure in quality control and more. As an example, in the reference lab I currently work in, a patient was referred with an antibody which reacted with all cells tested. The autocontrol in the DAT was negative, indicating the presence of a possible antibody directed against a high incidence antigen, meaning an antigen which most of the population possesses. The serologist performing the workup phenotyped the patient, which revealed a phenotype of M negative N weak plus. Can you recall the antibody which can be developed in patients lacking M and N? I'll give you a second. The patient ended up developing an antibody known as anti-ENA, which is commonly seen in patients lacking M negative and N, lacking M and N, so they're M negative and N negative. An extremely rare antibody known as anti-ENA is very clinically significant. And this example demonstrates that an investigation is warranted when weak reactions is observed during phenotype. In this case, the serologist noted the N was weak plus, and variant or null antigens can demonstrate weak phenotyping. The note area reiterates that grading should be standardized across the lab to eliminate subjectivity during testing. To do this, you'll want to standardize interpretations. You'll always want for the technologist to view the interpretation table in each of your blood banks. One solid agglutinin is a 4+, and so on down the line. We have a weak plus, a 1+ weak, 1+, 2+, and 3+. We also have no agglutination, which is considered a 0, and we have mixed field hemolysis and partial hemolysis. So while you're training a newer technologist, you'll want to ensure the technologist is shaking adequately and erring on the side of caution. Vigorous shaking can result in false negative reactions, which are very misleading in your interpretation of an antibody identification. Number 2 states that grading systems should be available in a written procedure in your hospital. So all of you should be able to look at your SOPs and find a grading scale which you can refer to. Number 3 states some systems assign scores for observed reactions. This method is rather outdated and not used as frequently. I have not seen it in a lab in my region. There are some labs which still report the score of a titer, which we can review later, but this is also quite infrequent. In terms of memorizing how to grade a scoring system, I would not recommend trying to memorize this for the SBB exam. Lastly, the grading system is not necessarily applicable to newer technologies such as solid phase. So this grading scale is really a macroscopic test tube table. The grading scale of automated methods are available in the package inserts and through the manufacturer's directions. Method 3-1, using immediate spin compatibility testing to demonstrate ABO incompatibility. The principle states compatibility testing is performed in order to prevent transfusion of incompatible donor red cells that might result in an immune-mediated hemolytic transfusion reaction. Details in the general principles of compatibility testing are found in Chapter 17 of the Tech Manual. The age of the specimen must comply with the requirements per our standards. This method is very straightforward. We'll often see this, and per the standards, we must have either an electronic or tube serological system to determine compatibility between ABO of the donor and the patient. So this procedure, you'll add a 3% solution, 2 drops of plasma, 1 drop of cells, and this remains consistent for all cross-matching. So you should know at this point that we always use 2 drops of serum and 1 drop of donor red cells when we're cross-matching. That's the one test that I recommend that you know the drops involved. If the reaction is either hemolyzed or has agglutination, we would call that incompatible. This method also discusses EDTA saline and why it's used. I haven't seen it used in the reference lab, but if you'd like to read a little more about it, it's in here. This method is very straightforward, so we'll move on to the next. Method 3-2 is the saline indirect antiglobulin test procedure. The principle states an indirect antiglobulin test demonstrates in vitro reactions between red cells and antibodies and is used in antibody detection, antibody identification, cross-matching, and blood group phenotyping. The specimen is serum or plasma, and it also must comply with pre-transfusion requirements. The procedure begins with adding 2 drops of serum or plasma to a tube and then adding a suspension of group O red cells that's in about 3 to 5% saline. So this is where our saline is added, but really it's just 2 drops of serum and 1 drop of a red cell suspension, group O. Then as the procedure continues, we take this all the way to the indirect antiglobulin testing phase. So in saline method, this typically takes 30 to 60 minutes. And one of my colleagues for her SBB project performed a study in which she differentiated between Liss and saline method, and she discovered that and confirmed that there was not any difference in the strength of reactivity using Liss or saline method, but really the benefit of Liss over saline is the amount of time of the incubation period. And so saline takes about 30 to 60 minutes, whereas Liss takes about 10 minutes. So that was an interesting abstract that she wrote, which you can actually find at the Phyllis Unger case studies this year. The next step is to always try to observe for hemolysis, because that is also indicative of a positive reaction. I'd also just like to note on the side that there is a difference between IAT and AHG. Sometimes they're used interchangeably. We also hear the word Coombs phase used, and that is not actually correct. So the IAT refers to the indirect antiglobulin test, and AHG refers to the reagent. So we use anti-human globulin in an indirect antiglobulin test. So it makes sense that we could use these two synonymously, but in essence, the test itself is referred to as IAT. So when you're documenting that you perform this test, you need to use the word IAT and not AHG. Method 3-3 is albumin or Liss additive indirect antiglobulin test procedure. It's essentially the same thing as the previous method 3-2, where we talked about saline. Instead we're using albumin or Liss. So the principle of albumin or Liss IAT is it's an IAT test that demonstrates in vitro reactions between red cells and antibodies. It's used in antibody detection, antibody identification, cross-matching, and blood group phenotyping. The albumin method may reduce repulsive forces between cells and thus promote agglutination. Use of a Liss additive accelerates antibody binding to red cells. In many of the textbooks, you'll actually find they refer to Liss as reducing the zeta potential. So I encourage you to look at the Harmoning textbook. They have a really good schematic of the repulsion forces that occur between an antibody and a red cell and how Liss is involved in eliminating those forces. The specimen is similar to the last one. It must comply, and it must be serum or plasma. Liss is available for commercially. It's available, and so is bovine albumin. These two reagents can be used as enhancement media. Bovine albumin is not seen as frequently, although I do see it sometimes, but not necessarily in cross-matching or antibody identification. We typically see Liss instead. It's the same method as we discussed before. However, Liss, you'll only have to incubate for about 10 to 15 minutes. Albumin, much like saline, is for 30 to 60. The interpretations are almost identical, and one thing about Liss is that we're allowed to spin the test tubes at 37 to observe for hemolysis, which you cannot perform with PEG. And so this is a great method to detect antibodies which may be reacting at 37 degrees Celsius, such as a cold autoantibody. So we typically run cold autoantibodies with Liss. And Liss is also characteristically more sensitive to cold autoantibodies, whereas PEG is more sensitive to warm autoantibodies. Method 3-4 is much like method 3-3. It's just more specific to Lys suspension. I'll let you read over it, but again, it takes about 10 to 15 minutes to incubate at 37. Okay. Method 3-5 is our PEG indirect antiglobulin test procedure. I'm sure you've all used PEG before. The principle is very similar to Lys. However, PEG is an enhancement media that interacts differently than Lys and saline method. PEG method accelerates the binding of antibody to red cells by steric exclusion of water molecules in the diluent. You'll need to know that for the SBB exam that PEG is involved in water removal and exclusion. The procedure is much like Lys, except we do not, and it says this in bold, centrifuge after 37, and this is because of the precipitate that can occur due to the interaction of polyethylene glycol and patient serum. Just as a kind of a funny story, if you check out the manufacturer's directions for polyethylene glycol that's manufactured, typically most places get it through Immucor, but you can also get it by other manufacturers. PEG actually has a little bit of Lys in it. And so I was attending a lecture series at one point where somebody recommended that we change the name to PISS, but maybe that might not be the best name for PEG. I kind of like PEG. Anyways, the interpretations are similar to Lys. The controls are similar to Lys. So please read over those if you'd like to. The notes for PEG are a bit different than Lys. Number 2 I thought was very valuable to know. In this procedure, centrifugation after 37 is omitted because red cells will not resuspend readily. I don't know if you've ever accidentally spun PEG and after incubation. If you have, you know what happens. You'll kind of see almost like clumping, but really, actually, this is where we would call it a precipitate. And number 3 says, using anti-IgG rather than polyspecific AHG to avoid unwanted positive reactions caused by C3 binding autoantibodies. Precipitation of serum proteins when PEG is added appear to be related to elevated serum globulin levels. At least 4 washes of the red cells at AHG phase with agitation will fully resuspend the red cells and prevent the problem from occurring usually. Alternatively, the test may have to be repeated using a method that does not use PEG. So PEG in the reference lab is our most sensitive test tube method. Typically, we'll begin an antibody screen using Lys, and if Lys is negative with all cells, we'll then move to PEG. If PEG is negative with all cells, we can then use another method if the hospital requests it. We're actually looking for reactivity in the reference lab, whereas in the hospital you might not really want to use the most sensitive method all the time. So we may, after PEG, use solid phase gel or Fison treated red cells to enhance the antibody antigen interaction. Method 3-12 is a one-stage enzyme procedure. One-stage methods is where all ingredients are added at one single stage. I googled the definition of one-stage methods before doing this presentation to get a good definition, and there is actually a one-stage cookie recipe method where all ingredients are added at once, and needless to say, I never got a good definition. I was really distracted. But much like the cookie method, the one-stage enzyme procedure is where all of the ingredients are added at once. The one-stage enzyme procedure principle states that enzymatic digestion of red cell antigens selectively removes certain antigens while preserving or enhancing the reactivity of others. The enzymatic reaction occurs on the red cells. The cells are washed 3 to 4 times. AHG is added and centrifuged, and the technologist grades the reaction. It's pretty straightforward. 2 drops of serum, 2 drops of 3% solution of suspension of red cells, and then 2 drops of papain. Papain is an enzyme. You incubate for 15 minutes and observe for agglutination. You'll perform this method at IAT. Typically, there's no enhancement media added because your enzyme is considered your enhancement media, so no PEG or LIS. Also noted at the bottom, number 7, a control should always be included to ensure that your method is detecting what you want it to detect. Method 2 below here is a 2-stage method, and you guessed it, the principle is the same, but the method takes a bit more time because you have to perform it in 2 different stages. The method is really dependent on the manufacturer's directions. So in this case, understand what 1-stage and 2-stage methods are, how they vary. You don't necessarily have to memorize the number of drops. There are benefits and disadvantages to either method, which one should consider when budgeting the laboratory. Microscopic examination is not recommended in these methods, as noted in the limitations, because of possible false positive reactivity that could occur. We will review this week how serologists use enzymes to investigate antibodies, but I'd like to comment on the sources of these enzymes for a minute because there is some interest in the source of these enzymes to me. It's quite interesting. Proficin and papain are 2 commonly used enzymes in the reference laboratory. Some reagents, I think Immucor has a panel where the cells come Ficin treated, so you don't have to treat them yourself, but in the reference lab we often have to treat these cells independently because we're selecting the cells. So Ficin is a proteolytic enzyme that comes from figs, and papain is also a proteolytic enzyme that comes from papaya. Shown below here is the antigens which are depressed and the antigens which are enhanced. There are variable antigens, meaning you can either remove them or they remain. It depends on the red cell that you're treating. Ficin and papain characteristically remove M, N, and the Duffy system. The other ones are more for investigational use since they're not as clinically significant as M, N, Duffy A, Duffy V. Trypsin is also an enzyme. It's derived from hog's intestine, and it's a proteolytic enzyme that cleaves peptide chains. So this one depresses the M and N And so we can use this as an advantage during our investigation if we need to rule out Duffy, for example, the Duffy system. I've added a picture here of papain just because I sense that a lot of people haven't really seen this reagent because it's primarily used in the reference lab. So we actually get bottles of these from a manufacturer. Typically it's Immucor, but it can vary. This one is from Biorad. So the bottles come in a sleeve and there's 10 of them. At the bottom of the bottle, you'll see little white granules, and that's the papain. It comes freeze dried, meaning it's a white powdery solution. We then add 2 mLs, so approximately filled to this line here. And then at that point, our reagent is now considered reconstituted, and we can use it for patient and donor reagent cell testing. In our final method, we'll talk about performing a direct antiglobulin test, method 3-14. The principle states the direct antiglobulin test, or DAT, can determine if red cells have been coated in vivo with immunoglobulin, complement, or both. It is used primarily for the investigation of hemolytic transfusion reactions, hemolytic disease of the fetus and newborn, autoimmune hemolytic anemia, and drug-induced immune hemolysis. See the technical manual for further details on the principle. Just some important notes to point out. The DAT detects sensitization in vivo, so in the patient's circulatory system. This is a very important concept to recognize. The IAT, indirect antiglobulin test, which we covered previously, detects in vitro sensitization, meaning in our test tube system, where this is actually coming from the patient. Also, these 5 mechanisms which the DAT can be used to investigate all involve the word hemolysis. This is extremely important because it demonstrates that this test gives us a lot of information and clinically significant information. So it can create some confusion sometimes because there's so many different pathways that the DAT can lead us to, but it's a very important test that we perform in the reference lab on essentially every single patient. The DAT is not typically performed on all patients in a hospital blood bank, but it is for patients in a reference lab because we're investigating possible antibodies of clinical significance. The reagents involved include the anti-human globulin and a control reagent. The control reagent is used if all series of the DAT are positive. It can either be saline or 6% albumin. So we'll talk about the procedure itself, but an important aspect to consider is we use a polyspecific reagent as a screening tool, and then we reflex to anti-IgG and anti-complement if our screening is positive. If all 3 of these are positive, then we'll include a control to ensure the validity of the test. If all 4 are positive, we then have to denote that the test is invalid and investigate why it is invalid. And then resolve the interference and perform the DAT so we get a clear result. Also, an important note is the difference between polyspecific reagents and monospecific reagents. This is especially important in the reference lab. The reagents we have, which are monospecific, are typically more expensive, first of all, but second of all, will tell us exactly what target is positive, whereas a polyspecific has multiple targets, and therefore we may need to investigate the specificity of the target. The procedure is quite simple. You've all probably performed one, but I'll just go into how to do it. You add 1 drop of your 3% solution. You wash 3 to 4 times. You'll immediately add your antisera and centrifuge and grade your reactions. And just like I noted above, you're going to confirm the validity of your negative results as indicated by the manufacturer. The things that I highlighted here is number 2 was very important. A negative DAT result does not necessarily mean that the red cells have no attached globulin molecules. Polyspecific and anti-IgG reagent detects 150 to 500 molecules of IgG per cell, but patients may still experience autoimmune hemolytic anemia when IgG coding is below this level. There is a test to determine if the patient is experiencing hemolysis due to autoimmune hemolytic anemia but continues to have negative direct antiglobulin tests, and that's a test which is more sensitive than detecting 150 molecules, which is actually quite small. It's called the Super Coombs test. We've probably all heard it before. And it's a more sensitive method to determine autoimmune hemolytic processes. The last note I'd like to point out is that no interpretation can be made if the control reaction is reactive, and it lists some uh, procedures that you can perform here to remove and investigate the extra reactivity that you're seeing. So warming the red cells, washing with warm saline if you suspect a cold, or even treating the cells with DTT or 2-ME. Also in the notes area, one of the limitations of this test is that cord blood samples may be contaminated with Wharton's jelly, which may cause confusing reactions, and so additional washes may be warranted.